So today we have the pleasure and honor to have two great speakers. The first one is Professor Takashi Sugawara, who is also a friend. And the second is another great friend. We all know him because he is one of the organizers of these meetings and also ACNS meetings, Professor Raja Krishnankuti. So hello to both of you guys. For today, Raja will, step on the other side from the organization to the speaker seat, right? But let's start. Thank you to Professor Yoko Kato, of course, who is our main sponsor. Thank you very much. And thank you to Ishu Bishnoi, who is a co-moderator of mine. So Professor Takashi Sugawara is the first speaker. He is a very well-known Japanese neurosurgeon. He had a very wide training in neurosurgery, especially in cerebrovascular and skull base. He did also a fellowship at the Arkansas Neuroscience Institute. And he has this main interest in skull-based surgery. And actually today, he will talk about surgical strategy for lesions in and around the cavernous sinus. So a very, very challenging kind of surgery. I think we are all very interested about this kind of surgery. So I want to ask Professor Takashi Sugawara to start his lecture. Thank you very much.
Okay, thank you very much, Professor Pelletti. And I'm gonna, good evening and good afternoon, maybe good morning, and everyone. And today's I'm gonna talk about the surgical strategy for lesion in around the cavernous sinus. And first of all, I'd like to say thank you very much for giving me this opportunity to all the association members, and especially to the Professor Yoko Kato. And again, I appreciate Professor Yoko Kato to give me this many kind of opportunity to present my talk in the world. And let me introduce myself briefly about my background, the skull-base surgery. And then I learned skull-base surgery under Dr. Christ, especially about the transcavernous approach. And this here is a Christ, and everyone knows about him. And he is one of the most famous skull-base neurosurgeon. And this is my favorite picture because my big mentors, three big mentors in the same picture, and these three, and I was here. And also Professor Christ was a professional soccer player, and he has a soccer field in his house. And this is Professor Christ, and this is me. And he renewed his Arkansas Neuroscience Institute and held the opening ceremony in 2019. And I attended this ceremony. And here is Professor Krish, the President Lenz, Al-Mufti, Professor Helesimi, and Professor Ture. And these all big guys are Yasaju's family. And let's move to my presentation. The surgeons for the lesion around the cavernous sinus is still challenging, especially invading cavernous sinus of optic sheaths and the glomerular cave. The exposure of this region is sometimes necessary, but have a risk of cranial nerve injury. In this presentation, I show the surgical technique of cavernous sinus and the glomerular cave opening for the paracrineal tumor resection. I'd like to show my videos. As for surgical strategy for paracrineal tumor, the tumor invading cavernous sinus is basically left but removed if it is soft and malignancy or visual function is already eliminated. If the tumor invades optic cyst or oculomotor cave, they are widely open. Then the tumor is removed as much as possible to decompress the cranial nerves. And the temporal dura propria tumor attachment, for the meningioma, is peeled from the cavernous sinus lateral wall and received with tumor. The temporal dura defect is reconstructed with the temporal fascia or pericranium and fat tissue, tightly. And this is from my paper about extended orbital examination. And here you can see the medullary fossa widely exposed and the lateral wall cavernous sinus here. And this is a schema. And there is some triangles to get into the cavernous sinus. And these are the frequently we use to get into the cavernous sinus, like paramedial triangle or Parkinson's triangle, and lateral and anterolateral triangle. These two are very safe window to the usually safe, but sometimes these 6 nerve is come down here, so sometimes we have to take care about this pathological anatomy. And this anteromedial triangle, so-called Dolenz triangle, is also very useful. And I'd like to mention about the oculomotor cave, like this space. There is a space here around the oculomotor nerve, like a Meckel's cave. And this place is so-called porus oculomotoris place, entrance to the cavernous sinus. And this place is very important because the tumor can easily invade to this space and compress the oculomotor nerve and damage these cranial nerves. And then we have to remove the tumor in the oculomotor cave to decompress this oculomotor nerve to recover their functions. And this picture was from Professor Eichlish's paper about the transcavernous approach. And here is the oculomotor cave. Maybe many people call this space oculomotor system, and mobilization of oculomotor nerve is very useful to go to the basilar artery. And move to the video. And this case was left small medial spinal ring meningiomas, and open the orbiter and unroofs the supraorbital fissure here, and peels the temporal dura propria from the lateral wall of cavernous sinus, and the anterior process was removed. And you can see here the C3, and here is lateral wall of cavernous sinus, post nerve and B1, B2. You can see it, and get into the intradural space and remove the. Here you can see the oculomotor nerve here, and remove the tumor, intradural tumor. And then go back to the outside of dura and remove the temporal dura propria as the attachment of the meningioma. Then remove this attachment, then we can achieve the Simpson grade 1 resection. And open the cavernous sinus and with the C4, but fortunately, the tumor didn't invade to the cavernous sinus. Then the Simpson grade 1 resection was achieved. And the dura was reconstructed with a pericranium and with a fat watertightly. And she had a transient oculomotor palsy, but improved completely in just 3 days. And the next is also the cranial meningioma invading into the optic sheath and the glomolar cave. And here you can see optic sheath here, and the tumor invaded to the optic sheath and open the optic sheath and remove the tumor in the optic sheath. Here's the optic nerve here. And then the tumor also invaded to the oculomotor cave and the cut the tentorium, and you can see the anteropetrocular ligament here, and cut them and mobilize the promoter nerve, and further cut the tentorium and longitudinally to the oculomotor nerve. And here you can see the tumor in the oculomotor cave, and remove these tumors and decompress the oculomotor nerve like this way. This is, I think, very important procedure to decompress the oculomotor nerve like this. And here's the attachment. This is the final view. And the next is also crinoidal meningioma invading to the optic sheath and also oculomotor cave. And then here is the IC encased with the tumor, and remove the temporal appropriate and cut the tentorium again. And the tumor invaded to the oculomotor cave like this. And cut the tentorium for the, and here's the tumor invaded the oculomotor cave like this. And remove this tumor here. And this is final view. And she has a transient oculomotor palsy, but improved completely in 5 weeks. And Simpson grade 1 resection was achieved. And the next one has a craniofacial meningioma, and she had almost complete visual, a visual disturbance like a counting figure, and almost complete right oculomotor palsy. Then I have to remove here. I have to remove the tumor in the oculomotor cave to recover the oculomotor nerve function. And this is a lateral wall of cavernous sinus, third, fourth, B1B2B3 here, and open the Parkinson triangle. But the tumor was very tough, so I gave up to remove the tumor in the cavernous sinus because she was 74 years old. But I have to remove the, here you can see the sum, I remove the tumor around the oculomotor nerve to recover the oculomotor nerve function. Here, again, I open the oculomotor cave like this way, and the tumor compressed the oculomotor nerve like this, and I remove the tumor. Here is a posterior fossa, and the sana was decompressed like this. And also temperature appropriate as attachment was removed. And dural defect was plastic with percranium, watertightly. And her oculomotor palsy improved completely in 8 weeks like this. the tumor in the cavernous sinus was left, so Simpson grade 3 resection in this case, but the process was recovered. And this was a chondrosarcoma case, left chondrosarcoma case, and open the anterolateral triangle here, and remove the tumor through the Parkinson triangle, anterolateral triangle. Here's also Parkinson triangle, and remove this tumor. Here is a McCabe, and this is a posterior fossa. And check the IC by the Doppler. And interdurally, there is no tumor. And the tumor was removed. And he also had the complete femoral nerve. This is not healthy, but it recovered almost completely, like this way, but except for the upward. But he has no problem in his life now. And this case, the recurrent craniofacial atypical meningioma, he has 4 times she went underwent the 4 times surgery and 4 times gamma knife and 1 EBRT, and she has a complete loss of visual function, left visual function. So I sacrificed all of the nerves of the oculomotor ocular movement, because here you can see the tumor compressed brainstem. I have to decompress this brainstem, and this is inside of the dura, and you can see the optic nerve here, tumor on C2, and go back to the lateral wall of cavernous sinus, and found the C4 with the Doppler and remove the tumor. The tumor is, as you can see, very tough because maybe gamma knife or EBRT effect, and also found the optic oculomotor nerve here, and I sacrificed this nerve, and then we can get a wide space here, and also very tiny perforator should be preserved in the tumor. In the preponderant system was also removed, and the C1 to C5 was left here. And the basilarity, you can see here, basilarity and the contralateral oculomotor nerve. And her brainstem was decompressed like this thing. And also this case was recurrent carcinoma. So usually in like this case was intraoperative, but there's no way to there's no other way to remove the tumor. So we decided to operate this case, and cut a B2 here, and you can see the third nerve, fourth nerve in B1, and cut the optic nerve and open the paramedial triangle and remove the carcinoma in the cavernous sinus like this way. And cut the B1, and you can see here the 6th nerve, and cut 6th nerve, and cut the 3rd nerve. You can see the C3 and C4 here, and remove the 3rd nerve and 4th nerve, and the B1, and also 6th nerve. All of the nerves in the cavernous sinus. And move the cavernous sinus to the backward, and tumor was almost completely removed. And amazingly, he underwent the EBRT and no recurrence for more than 4 years. He was still alive. And this is a crown facial meningioma. He has right oculomotor and abducens nerve palsy, and here it's an anterolateral triangle. You know, as I mentioned, anterolateral triangle is very safe place. And of the Parkinson triangle here, and you can see the C4 and 6 nerve here, and again 6 nerve, and C5 here. And develop the tumor, open the Parkinson triangle further, and you can see here the 4th nerve again, and develop again. And here you can see the mango epiphyseal trunk. And then further develop the tumor. C4 again. Now, of course, it's impossible to remove all of the tumor in the cavernous sinus, but I try to remove the tumor in the cavernous sinus as much as possible. And also, his oculomotor and abducens nerve palsy completely improved 9 weeks after surgery. And this is a preoperative MRI and postoperative MRI. Maybe 80 to 90% of tumor was removed. And this is a fat tissue I put in. And this is the last case in cavernous sinus meningioma, very small tumor, but she had the progressing left oculomotor and abducens nerve palsy and facial epiphyseal. So I operated her to improve her symptoms. And from temporal craniotomy, and here's the sphenoid ridge and supraorbital fissure. Unroof the supraorbital fissure like this way. This is a periorbital. And this is a middle meningeal artery here, and peel the temporal appropriate away from the cavernous sinus lateral like this. Here you can see the boundary between the temporal appropriate and the periorbital here. And here is the cavernous sinus lateral wall. And this is an anterior process, and remove this process. Usually I use rewire or drill to make it as small as possible. But we have to take care about the optic nerve here and the third nerve here, not to damage. And here you can see the optic sheath and B1, B2, B3 here. And here you can see the veins, important vein here. And then get into the interdural space and the tumor. The tumor in the dura was very small in this case. And then remove the tumor inside of the dura first. And then you can see the oculomotor nerve here. And become perforated around your, sorry. And then go back to the outside of the dura, and here is an anterolateral triangle. Open this triangle and develop the tumor. And usually relatively safe space here, but here you can see the sixth nerve. Sixth nerve was moved downward by the tumor, like this space. So we have to take care about this. So sixth nerve is most important nerve. I mean, difficult to find in this region. And then go back to the intraorally here and the oculomotor nerve here, and they compress the oculomotor nerve because tumor compress the oculomotor nerve medially like this way, and very gently, softly remove the tumor and cut the tentorium. This tentorium was thickened by the tumor like this, and cut the tumor, cut the tentorium like this way, and gently remove the tumor here. And then further open the oculomotor cave longitudinally with a oculomotor map like this way. And here you can see the tumor in the oculomotor cave again. She has a big oculomotor cave like this. And also the tumor, again, still opens the oculomotor cave here, the big space here. Maybe more, we need to open further to remove the tumor and decompress the oculomotor. And then here you can see the tumor compress the oculomotor nerve from the medial side. So we have to remove this tumor, then open the optic cyst like this way. And here is C2 and the oculomotor nerve. The tumor invaded to the optic cyst a little and cut these tumors with dura. But still tumor was here, and this is a dura, and this space was anteromedial triangle, so-called Dolenz triangle. I mean the posterior part of the Dolenz triangle, and then remove the tumor, develop the tumor with the cursor like this way. And here is a relatively safe space. I mean, without the third nerve. And after decompression from the medial side, then went to the paramedial triangle. This is a dura. So, but I couldn't find the fourth nerve this case. Then maybe I think the fourth nerve must run like this way, but I couldn't find. This is, I think, rare case because usually fourth nerve is very easy to find, but in this case, fourth nerve was covered by the tumor, and maybe running like this way, and still develop the tumor through the paramedial triangle. Here, you can see the posterior fossa. This is inside of the cavernous sinus, and went to the Parkinson's triangle and remove the tumor. I checked the maybe C4 here, and then I have to take care about the sixth nerve. Sixth nerve may be here. So gently bring the tumor like this way. And here you can, I found the sixth nerve here. Then further remove gently and softly. And this, I went to the microscope from this space like this here. And here is a microscope. And still tumor was here. And then remove all of the tumor. But yeah, but this is a very interesting movie. I stimulate the third nerve here, and you can find the moving. You can see the moving upper superior rectal muscle like this. Can you see this here? And this is a final view. And I also stimulate the third nerve here. And this is electroencephalography. And then this movement show the right and left movement. And then and also stimulate the sixth nerve. And electroencephalography shows the movement of eye movement, left and right movement. Then this is the final. And oculomotor nerve was completely decompressed like this. And I close the dura with fat tissue like this way, drive to the window. Okay. And this is a preoperative video of oculomotor palsy and cytosis. And this is just after the surgery. Oculomotor and abducens nerve palsy transiently worsened like this. But this is with in 1 week, after 1 week, and almost recovered eye movement and ptosis. And the tumor was maybe 90% tumor was removed. So in paracrine region, it is possible to remove the soft tumor in cavernous sinus. However, tough and rigid tumor is hard to remove without cranial nerve injury. And tumor resection in the optic cyst and the oculomotor cave can not only preserve but also improve cranial nerve function safely. Thank you very much.
Thank you. Thank you very much, Professor Sugawara, for this impressive presentation, really with very, very difficult cases. I am sure there will be many questions by the audience. I want to start with the first question and then let other people ask you other questions. Nowadays, many people think that it is not required, let's say, to remove completely some tumors of the skull base because some people say it is okay to remove just a part of the tumor and then leave the rest of the tumor to gamma knife, for example. You showed many cases with Simpson grade 1 removal. So I would like to ask you how to balance between the need for total resection and the possibility of sending the patient to gamma knife for eventual residue of the tumor. How to balance between the risks of insisting with surgery until the end and this option.
Thank you very much. Very important question. Actually, recently I experienced many cases. Someone removes the tumor partially, and then the patient underwent the gamma knife, and then the recurrence occurred, and then I operate. It's very tough surgery after gamma knife because the tumor was got tough, very hard, and I think, and also as for atypical meningioma, it is impossible to control with gamma knife completely. Then I think it's important to remove as much as possible at the first surgery, and then, but of course, the cranial nerve damage, we cannot damage the cranial nerve at the surgery. So I think it's very difficult to identify it's I can preserve the nerve function or not. So I think we need experience, and I think it is very important to remove as much as possible. But as much as possible is difficult to explain.
Yeah, thank you very much. Some questions from the audience, please. Yes, I can see Vladimir Balik.
Yeah, hi guys. Thank you very much, Professor, for nice presentation. My question is, how many cases, I mean, how many meningioma of cavernous sinus ended up as a total resection? And how many cases you did only as a partial resection?
Actually, completely total resection is impossible. Maybe, in my case, Simpson grade 1 case was, the cavernous sinus invasion is very small. And so actually, it is very hard to remove all of the tumor in the cavernous sinus. So then I have to say that as much as possible, like I showed.
Yeah. Thank you, Professor, for such a nice and very elaborative lecture. I have one question. Like, this area is very dangerous, and if you find calcified hard mass, calcified meningioma, which is engulfing internal carotid artery and also the bifurcation, have you ever faced such kind of tumor, and how did you manage that situation? Like those who are not suckable with the CUSA.
Calcified tumor or invading to the IC?
Yes, yes.
Actually, I didn't show such a case today, but as you mentioned, sometimes very tough, hard, and calcified. tumor in case I see. So, but sometimes invade into the IC wall. In such case, it's very dangerous. But in such case, the angiography shows the narrowing the IC. So if the IC narrowed very narrow, I think I have to take care about the IC injury. And if I show the QSAR is very useful for such a case. QSAR, now QSAR has a tissue select mode. Tissue select mode can preserve the IC wall. I think it's very useful. I usually use QSAR.
So, Professor, have you, sorry for the interruption, I faced one case where the tumor was very hard and calcified. The tumor was even not able to cut with the knife. So, in such kind of situation, how do you cut the tumor and, of course, saving arteries?
And actually, I usually use a QSAR. QSAR is very useful, even if the tumor was calcified. But if you feel dangerous, you have to give up to remove the tumor. And okay.
Oh, thank you, Professor.
Other questions?
One for me, if I can.
Yeah, sure, Ricardo.
First of all, good morning to everybody, and konbanwa from Japan. Thank you for the nice presentation. And just a simple question. For young neurosurgeons that want to learn this kind of approach and this kind of surgery, what's your suggestion? Apart study the anatomy, that is always a good idea, I think. Cadaver lab, other kind of technique to improve the knowledge, the movement.
Okay. First of all, I think anatomy is most important. So you should learn the anatomy with a cadaver or other. And also, normal anatomy, you can learn normal anatomy with cadaver dissection. But the other, another important thing is you have to understand the pathological anatomy. Tumor compressed nerves, maybe upward, downward, or laterally. And so you have to understand where is the tumor coming from. I mean, the attachment origin. If you know the origin, that you can understand that where is now was moved, where the nerve moved. So normal anatomy is very important, and also the pathological anatomy is very important. And if you don't know the anatomy, I think you feel scary. So we also, for me, I think we have to learn more and more about the anatomy.
I think Temur Dushanov.
Thank you.
Thank you. Question.
Thank you for your great presentation, Professor Takeshi Sugawara. This was very good lecture on very advanced neurosurgical techniques. I have a question. We have many cases experienced in our center when removing meningiomas that surround the internal carotid artery completely. So after the removal in preoperative period, post-operative period, there were complications like vasospasm, like spasm of carotid artery and ischemic stroke in about 20–30% of cases. So how you deal with this? And the second question is, when there is no possibility to remove the tumor around the carotid artery, have you done with vascular team the bypass and completely trapping the internal carotid? Thank you.
For first question, I have only one case with vasospasm. Like I showed the videos. I expose from C1 to C5 and sacrifice all the nerve. In that case, I experienced vasospasm, but very short time. I mean, transient, only few hours. The vasospasm recovered. So, as you said, I think it's very important to care about the vasospasm, but only one case I experienced. And the second question, what was the second question?
The second question was about the possibility. Have you done the bypass internal carotid and completed trapping internal carotid?
Actually, I have no case with the bypass case. But if I had thought about bypass for one case, but actually, first I use a gamma knife, try to gamma knife and watch the tumors grows, and maybe I need a bypass. But I have never done before.
Thank you.
Thank you. Other questions from the audience? So if there are no other questions, I want to thank again Professor Takashi Sugawara for a wonderful lecture about such a difficult surgery. And maybe we can move on with the second lecture. Please, Ishu Bishnoi, can you introduce our next speaker?
Hello, everyone. And now I would like to invite our next alumni speaker, Dr. Raja. He is my dear friend, and he is currently working as associate professor in the Department of Neurosurgery as Government Medical College, Thiruvannamalai, and he is executive editor of Asian Journal of Neurosurgery and also chairman of Educational Committee, Asian Congress of Neurosurgical Sciences, and he was a fellow from Fujita Health Association, Japan. He has published more than 33 papers, and today he will present about intraoperative aneurysm rupture do's and don't. So I would like Raja to present his presentation.
Hello, everybody. Good afternoon, good evening to all my dear friends. Professor Sugawara, Yoroshiku onegaishimasu. It was a wonderful lecture. Thank you so much. Thank you, my dear friend Alberto Felitti and Ishu Bishnoi, and above all, Professor Yoko Kato, for giving me this wonderful opportunity to present a topic on the alumni webinar. I would like to start my lecture. I hope you all can see me now, right? So, my lecture for today is intraoperative aneurysm ruptures do's and don't. I come from this small piece of land, elongated piece in the southernmost tip of India, which is Kerala. It is also known as the God's own country due to its lush green forests and scenic beauties. This is the place I work, and this is one of the largest tertiary centers in the state of Kerala. So regarding my topic, I hope you all might have read this book, Do No Harm, by Professor Henry Marsh. This is one of my favorite books, and in this, there is a chapter called Aneurysm. The context here is he has repositioned the clips twice, and his assistant says to him that there is a little bit out, says Jeff, who is his assistant. And Professor Marsh describes his feelings like, sometimes at these moments, my past disaster with aneurysm surgery parade before me like ghosts. Faces, names, wretched relatives I forgot years ago suddenly reappear. I struggle against my urge to finish the operation and escape the fear of causing a catastrophic hemorrhage. I decide at some unconscious place within myself where all the ghosts have assembled to watch me, whether to reposition the clip yet again or not. Compassion and horror are balanced against cold technical precision. I reposition the clip a third time, and it looks finally well placed, Henry Marsh. So I had never found a better description of the fear of an intraoperative aneurysm rupture than in this book described by Professor Henry Marsh. And when the aneurysm ruptures, there couldn't have been a better description by other than by Professor Michael Lawton, who said that it elicits an intense rush of emotions, not limited to surprise, but confusion, regret, tension, frustration, anger, excitement, and desperation. And these emotions can be overwhelming. We all have gone through this period of our residency, and during when an intraoperative rupture occurs, everybody loses their cool and there is shouting and screaming in the theater. And we all have been through this. And above all, we must understand that we should keep calm because you are a neurosurgeon and you have to deal with it often. Otherwise, what will happen is, this is an interesting study which came out in the Alumni Institute of Medical Sciences, where they measured the blood pressure of the surgeons who are doing clipping, and they found that during aneurysm clipping, their BP and pulse rate rises to very high values during the intraoperative period. So, as they say, aneurysms are not good for your own health. You should be always careful. Now, we always know that intraoperative rupture has a bad outcome, mostly. And in this article by Sampson and Bayer, they have mentioned that without intraoperative rupture, the favorable outcome is 88%, where it decreases to 62% with intraoperative rupture. And also the CARET study, they have noted that periprocedural death and disability increased from 18% to 31% in patients who experienced intraoperative rupture. So how to avoid an intraoperative rupture? Is there some magic? Where, in the words of Professor Michael Lawton, who said in his article that the steady rate of rupture over the time, despite neurosurgeons' increased surgical experience, suggests that no amount of learning and constant practice can overcome the dangerous combination of aneurysm fragility and surgical manipulation that sometimes precipitate rupture. As you see, this is the series which Professor Michael Lawton published when he was in San Francisco before he moved on to BNI. And this is a 7-year period where he has shown that the rate of aneurysm rupture has been more or less the same. But what has happened is the good outcome has increased over the period of time, so that the surgeon acquires the manuals necessary which can contain the intraoperative rupture over the years. So according to him, there should always be a prior thoughtful development of systematic contingency plan, and the surgeon must envision disaster in every conceivable form and then develop strategies for dealing with it. But however, in some cases of unruptured aneurysms, CFD can provide some clues. That is, CFD can delineate thin wall and thick wall regions in case of unruptured intracranial aneurysms. And we can be careful in approaching these areas. Now, Professor Hidehito Kimura presented this article, and he noted that low wall shear stress vector variant cycle represents a unique hemodynamic index calculated using hemoscope, and this corresponds to thin wall regions over the aneurysms. What are the factors associated with intraoperative ruptures? There are several factors, and as you see, early surgery, rupture status of aneurysm, SAH grade, anti-communicating location, thin wall aneurysms, blunt dissection, daughter sac, surgeon's experience. All these are factors, and the ones which are marked in asterisks, you can see various studies which have come in support or refuted this hypothesis that they cause higher incidence of intraoperative rupture. Classification. Sampson and Baer classified this into pre-dissection, actual dissection, and during clipping, whereas Lipsig et al. Further divided into 5 main types: pre-dissection, initial microdissection, definitive microdissection, clipping, and post-clipping. And in their series, the rates were higher during clipping and definitive microdissection. So how to prevent intraoperative rupture? Over the years, we have come across many ruptures, and we have derived the following factors that would help us, which is, I'll go each one by one. That is, read the scan, know the anatomy, choose a familiar approach, avoid blind retraction, know the sylvian, which is your highway to clip, and checklist before the point of no return, temporary parent vessel clips, sharp dissection around the aneurysms. So it is common knowledge that you must have where the aneurysm is pointing. A PCOM always mostly points towards the temporal lobe. It is attached to the temporal lobe. It may be attached to the, it may go below the tentorium as well. So avoid a retraction of the temporal lobe. And in an ACOM, inferior projecting ACOM may adhere to the optic chiasm, and undue retraction of the frontal lobe can avulse the aneurysm from the attachment and cause torrential bleeding. The second one is choose a familiar approach. Now there are different approaches that you are familiar with. You choose an approach in which is done at your place. I know there may be some places like in Japan, intrahemispheric is common for ACOM aneurysm. But if in other parts of the world, the pterional is the workhorse for aneurysms, whereas some places they do a lateral supraorbital, mini pterional, or a supraorbital. So choose whichever you find you are familiar with. So you are not in unfamiliar territory when you get into that zone of the aneurysm. This is an interesting article from Professor Anil Nanda's group, in which they analyzed the literature review of aneurysms between pterional approach and supra-burhole craniotomy. And they have noted that the incidence of rupture was higher in supra-bro craniotomy than pterional approach. Know the sylvian, especially in the MCA aneurysms. As you know, there are different types of sylvian fissure, which classically described by Professor Yasser Gill as atrophic straight, then frontal herniating, temporal herniating, and frontal and temporal herniating as well. Why it is important is that you must know your location of the aneurysm, in which part of the sylvian it is. Before that, we must know where your M1 is. And there is a great deal of how to approach the MCA aneurysms, like it is a focused exposure of the aneurysm and the proximal and distal parts of the MCA, whereas other prefer to first go over to the M1 and then come back to the aneurysm, where you can have a proximal control. Because in an event of an intraoperative rupture, it will be difficult to localize the M1 because of the torrential bleed that is happening in your area of vision. Now, this is one beautiful article by Park et al., who have analyzed how to find M1. That is, they have described the low angle of M1 and low M1 slope. When it is the angles are low, your vision of the microscope is parallel to that of the M1. So it will be difficult to find M1 vessel through the distal to proximal sylvian dissection. So proximal to distal is advised in this, whereas in the opposite, when the M1 angle is higher and the slope of the M1 is higher, the area of exposure in the microscope is higher, and you will be easily able to find your M1. So with this image, it will be more easier to understand now. This is the slope of M1 they have described, and this is the angle of M1 with the ICA. Now this line is the limbus sphenoidal line, and they have denoted the angle with regards to this limbus sphenoidal line. So you can find the M1 more easily in the second figure than in the first. The checklist. Before, when you expose the aneurysm, we always inform our anesthetist. That is the first thing we do. Then you unclog your suction tubes. because in case of a rupture, that is the only thing that will carry you home. Use one large bore suction, and if you are using some intraoperative monitoring like BIS, you lower the BIS so that it is equivalent to your burst suppression using whatever anesthetic methods that is available in your place. Like we give a sodium pentothal and we decrease the BIS. And use of temporary clips, and always anticipate rupture. A assistant should always be careful, and he should think that this aneurysm is going to rupture and how I can deal with it, how I can help, how I can contribute to the success of this surgery. The anesthesia agents for intraoperative rupture can be adenosine-induced cardiac arrest. Now, regarding this is it is short-lived and multiple doses may be required, and because of it is rapidly uptaken by the erythrocytes and the enzymatic degradation, you may have to give subsequent doses, but arrhythmias can also occur. Now, Benek et al., who directly compared proximal temporal clip occlusion with adenosine-induced cardiac arrest in unruptured aneurysms, and they have found that adenosine-induced arrest can be efficacious, harmless, and reliable alternative strategy for surgical treatment of complex cerebral aneurysms. Rapid ventricular pacing. Now, this is another important technique where you soften the aneurysm through a rapid ventricular pacing, and this was first described by Rowitt et al. In 1971. It is a safe and effective mechanism, and it is also of a rapid on and off mechanism. Complication rate is between 0 to 3%, and ventricular tachyarrhythmias can occur. This is another article in which they have mentioned that how temporary vessel occlusion can prevent intraoperative ruptures, and they have noted that with temporary clip in cases of ruptured and unruptured aneurysms, you can decrease the rate of intraoperative ruptures, and without it, the rupture rate is more. So temporary vessel occlusion is tolerated well in occlusion of larger arteries. Now, Sampson et al. Observed that infarction varied with specific arterial territories that were occluded. Now, these were surgeries of 100 consecutive aneurysms where there were no intraoperative complications. And they observed that when rate of infarction was higher in basilar territory regions and territory supplied by middle cerebral artery and anterior communicating and IC. So basilar was 41% and IC was 7. So IC is more tolerable to occlusion because of. So what is the safe occlusion time? Sampson et al. Noted 20 minutes is sufficient time. Suzuki et al. Noted that 20 minutes under normothermia is also a good occlusion time without any serious side effects. Sampson et al. Also noted in their study that in temporary occlusion, less than 40 minutes in 49 patients, there was no infarction, whereas infarction was noted when the occlusion time was more than 30 minutes. And intermittent versus continuous occlusion is also a topic. Like usually what we do is we recommend 5 to 10 minutes of occlusion followed by reperfusion. Now we must understand that it is not only the ischemia which is responsible, but also the reperfusion injury also is responsible for neurological deficit. In the last aneurysm surgery webinar, Professor Lawton also and Professor Ali Christ was also there, and they both agreed that there is no region which cannot tolerate an occlusion of less than 5 minutes. So 5 minutes is a safe occlusion time, after which you can reperfuse. Sharp dissection. This is the hallmark of microneurosurgery. Sampson and Baer noted that 75% of intraoperative ruptures occur because of blunt dissection as opposed to sharp dissecting techniques. Now, this is one example that this was one MC aneurysm which I operated before three weeks, and you see that one of the sylvian veins is densely adherent to the dome of the aneurysm, and I cannot see the one of the M2s. So I gently retract with my sucker in the left hand and try to dissect. I'll just run through it. And I always push myself to such maneuvers when the occasion comes, because it tests your skills, and your confidence also. Now you can visualize the other M2, and there is a nice exposure, and after which you can insert your clip safely. So what do you do when it ruptures? Well, the first thing is that control yourselves before you control the bleeding. Adenosine induced arrest can buy time. Never coagulate. I have found that many people coagulate that aneurysm, and they believe that actually coagulation would help. It may help in some situations, understand, but when the aneurysm just bursts open, your coagulation is not going to help. Never put cotton over the rupture point. Now this is again debatable, where many surgeons prefer to cover their and rupture point with a cotton patty and use a retraction to tamponade, and they go for temporary vessel occlusion. And I feel it may not help the purpose, because all the blood then enters the brain parenchyma and may further aggravate the swelling. So I never put a cotton. And avoid blind clipping. Blind clipping is very dangerous because you do not know where you are. You will, most of the time, 90% of time, you will accentuate the injury and worsen the situation. What can you do? Point suction. This is the only thing which will take you home. Point suction and control of your bleeding. So this is very important. In an event of rupture, clipping becomes secondary. This is one philosophy I learned from Professor Yoko Kato, who used to say that control of bleeding becomes your primary objective. And if in this case, if your assistant can clip, you give the clip to your assistant. And if you can control the bleeding, that is the best thing. So always remember, a rupture can happen to anyone. It is the next wrong step that will kill the patient. So you must always be careful. I'll go through some disasters that we have faced. Now, this is one case of ecom aneurysm, and we have put a temporary clip on the A1. Now look at the sucker. Look at the sucker. Yeah, so you see that sucker has caused the rupture. You can see fine serrations over the sucker. This part that happens because you drill your sphenoid ridge, keeping the sucker there, and this edge of the sucker become sharp. And then again another wrong step, we have put a blind clip, and that is further worsen the situation. Now I bring in a broad suction and point suction and salvage the situation there. Now we have salvaged the situation, but the problem here is we have not seen the opposite A2. Now we will look for the opposite A2. Yeah, and there we can find the opposite A2 there. And then we slowly release a clip on the A1, and then we ready for the ICG, and then again we manipulate the clip accordingly. Now this is one very interesting case. The case is an vertebral aneurysm rupture, but VA. You can see all the cranial nerves which are draped over the aneurysm. We have clipped one portion of the aneurysm, but you can see there is a lot of left behind that. Now we again try to insert a second clip behind that, and we then remove the first clip, and then we again try to reposition the clip, and that gives away the aneurysm, and there is torrential bleeding through the vertebral artery. We try to insert a cotton, but it is of all no use at all. Then we bring in a large bore suction there, and as you see, this large bore suction has I have taken the bleeding point directly into my sucker, and unfortunately the cranial nerves are all sucked in along with that point. And then we again reposition the clip, and it has not stopped again. And then again, I reinsert the third clip behind that clip, and we see that all the cranial nerves are sucked into the sucker. But this is one situation where we cannot help, and we reposition yet again, and then finally it stops. Now this patient actually had a very good outcome post-operatively. He had a stromy post-op period. Of course, he had a tracheostomy, and he also had a hoarseness of voice. Everything recovered in 6 months, and he still comes up for follow-up. This is another case where totally misread the situation. There was an hematoma, and we tried to dissect the arachnoid with the sharp scissors, and which has given away the aneurysm. Now we try to coagulate, then it again worsens the situation. Now you see that I had taken the point sucker and directed the bleeding point. Now it may seem that the aneurysm bleeding is controlled, but actually it is not controlled. I have directed that stream of jet of blood directly into my sucker. You can very well visualize it. Now again, after this, we put a clip and then dissect the whole aneurysm, which was adherent to the lobe. And then you finally reposition your clips and adjust it according to the findings on the ICG. This one was perhaps the worst rupture I have ever come across, because in here, luckily we had a proximal M1 which has been exposed here. There was a large hematoma in the temporal lobe, and as you see, this is one of the M1s, and I tried to insert my dissector into the just below the arachnoid, and it has given away, the aneurysm has given away. We could not analyze the situation. One cotton is kept, which again is of no help, and we finally try to blind clip it, but again it worsens the situation only. So the only thing which can take us home is a point suction. Then we come back to our M1, and finally we salvage the situation through a proximal M1 clip, and you see the hematoma and all is sucked out. And again, we take out the aneurysm, dissect it out, and we salvage the situation, remove the clips and reposition the clips again. And finally, we check for Doppler, both the M2s and M1, and also we check it with the ICG. Now, finally, we come to a stage where we can handle the situation without rupture. This is a bilobed ACOM, which is stuck adherent to the optic nerve. You see, retraction is always under vision. You expose the A1 on this side, and you generously resect the gyrus rectus, and you open the arachnoid over the optic nerves, that is opposite optic nerve, and you can see that aneurysm is stuck down to one of the optic nerves and the region of the chiasm. Now I slowly dissect the arachnoid from the aneurysm, and you can see one lobe, and with further resection of the gyrus rectus, the second lobe of the aneurysm slowly comes into view. There is the second lobe. And then we apply a temporary clip, and then all the vessels are in view. We dissect all the opposite A2, A1, the Hubner on this side, and then we slowly insert one of the dissectors, and we remove the temporary clip from the A1 and ready for ICG. And you can see that the aneurysm lights up. The opposite A1 has there is a trickle of flow in the opposite ear, and that was a hypoplastic side, and might possible that it has also gone into spasm. Then you again reapplied the temporary clip, and then you proceed towards final clipping. The first clip is put across the one of the lobes, and then you dissect the dome of the aneurysm from the optic nerve. You cut the attachment of the dome to the optic nerve. The second lobe still is remaining. We remove the temporary clip, and then we again put a clip over the lower part, and we're ready for the ICG, and the opposite A2 is checked, and everything looks fine. Hemostasis is achieved. I usually go ahead and do a fenestration of lamina terminalis always in my cases of ruptured aneurysms, and we give a generous saline irrigation, and this clip is going to lie over the optic nerve, so I put a piece of gel foam over it. Now, another technique which has been described is the cotton clipping technique by Professor Spessler and Barrow from BNI, and this is a video from there. Now they have inserted a clip over the aneurysm, and you can see there is a small bleb here. This bleb starts to bleed, and they reinsert a second clip there, but that has probably worsens the situation. I'll tell you why in the end, what could have been the cause. And they had to remove the second clip. We can appreciate the bleeding from the bleb, and they insert a cotton at the base, and they finally clip with the second clip, and ICG showed good flow. And this is another technique where from Belgium, where Professor Edegem has modified this technique by the use of a crushed piece of muscle and tamponing it with the clip plates. Now, special circumstances, we have heard of that scissoring effect of aneurysm clips. Now, why this happens is probably I said, like I said in the previous video, only the tip of the blades were applied, like that has caused the scissoring effect and caused the aneurysm to bleed. And this is one beautiful article written by Horiuchi et al. And from the Shinshu University, Japan, and they have analyzed why this happens in their lab, and they have come to the conclusion that without using the entire length of the clip blades, if you only apply the tips of the blade, and this along with the rotational forces then cut across the aneurysm, and this is what causes the scissoring effect. Now, these are special situations like blister aneurysms, which have very high propensity to rupture. There are specialized clips called sun clips, which can salvage the situation, whereas other describe resuturing the vessel and insert a silicone wrapping, and where are other people who directly use upfront bypass in case of blister aneurysms, which is published by Professor Baskay et al. From Wisconsin. In our unit, there were 33 aneurysms, and in the from March to December, and we had 24% of rupture rates and 1 mortality. In the last year, this was in 2019, I beg your pardon. In the last year, where we could not analyze our series because of Corona, there were different units and different people operating at different times. There was no uniform entering of data, and we have lost all the follow-up as well. So Corona has really affected us in our publishing department also. So how can we master this art of handling intraoperative rupture? According to the great Confucius, where he said that I hear, I forget, I see, I remember, and I do, I understand. Now, this is very important. Unless you do, you won't understand. So simulation techniques are great. Now, under the ACNS workshops, we organize around the world, which are a great place of simulation exercises. This is Professor Mori and Professor Kato, who are describing a scenario of intraoperative aneurysm rupture. This is Professor Mori, who teaches us how to clip and what is the correct position of clips. Here he is describing his line of closure in MC aneurysms. And in Japan, this is the Caslex company, which have come out with rupture aneurysm models. Professor Mori's group has presented this in the AJNS, and this each model costs around $1,000, and it is a very good tool to learn. I'll just show a clipping. This is Professor Mori, and that is my good friend Sandeep Talari. Sandeep is testing his biceps with the laptop.
This is breathing from the peak of the aneurysm. So first of all, we have to secure the M1. So this is temporary clip was placed on M1 and the breathing stopped. During the temporary clipping, we have to secure the neck, and we can perform the permanent clipping like this. And then don't forget to remove the temporary clip. See, removing the temporary clip like this. So this is basic procedure to manage the intraoperative feeding. The blood go to the deeper system. It causes acute brain swelling. So point suction is most important. As long as we are performing the point suction.
Yeah, Professor Mori describes that point suction is the only thing that will take us home in an event of rupture. Now, after this description, one of our webmaster Sandeep takes over for his chance of dealing with an intraoperative rupture. And the bleeding mechanism has been initiated. And the proximal M1 clip is inserted into the model. That is our good friend Thomas, who is loading the clips in most sterile fashion. And finally, they clip it. This is the intersecting clips. The clips blades are too long. And then again, and then finally you remove the clip. Now this is another method of clipping, which is suggested by Professor Kato herself. Finally, this clip. So these workshops are a great place to learn. I have learned a lot from these workshops. So overall, in conclusion, I would like to say that intraoperative rupture is a complication that requires some expertise to handle. A seasoned neurosurgeon by your side is very good for beginners. Learn from your past mistakes, review your videos, learn what precipitated the rupture. Think how you could have avoided it. As you watch videos of other surgeons also, and you can learn a lot from watching others. So thank you very much. It was a great experience to share my series with my best friends here in the Alumni. Thank you so much for your patient listening.
Thank you, Raja. Very nice presentation, and I think very useful for young neurosurgeons. you sum up many techniques to handle and to deal with such complication. Issue, do you want to start the discussion?
Yes. I would like to congratulate Dr. Raja. It was very nice presentation, and I myself have very much correlated with all the mishappenings and how to avoid them and how to learn. Now, as a cerebrovascular neurosurgeon, I myself will take some good message from this lecture and try to manage the thrill of intraoperative rupture most probably beautifully, or at least I will try to not to kill the patient during rupture. So now I will ask the audience to ask questions if they have, and please feel free to ask any question.
Can I ask Dr. Sugawara?
Actually, I'm very interested in adenosine use, but in Japan it is not permitted. I have watched a few times Dr. Christ did. My question is, how long the cardiac arrest is, and also, do you have any complication with using adenosine?
Unfortunately, I have never used adenosine, but I have summarized the literature review of the adenosine, which is there. But in our experience, we have never used an adenosine-induced cardiac arrest so far.
Maybe about 10 seconds or 20 seconds, very short
shortly,
time,
yeah.
I think.
It's very shortly.
But probably nowadays the pacing you mentioned can be safer, maybe, compared to adenosine. This is at least what I read about. I have no experience as well with adenosine, but probably electric heart pacing can be more safe, maybe.
Probably.
Some Japanese doctor is using adenosine. Usually the less than 1 minute. They have collaborate with anesthesiologist. Maybe they can discuss before surgery. Maybe just surgeon ask anesthesiologist, today I want to such the cardiac arrest time is certain second, something like that. So then the anesthesiologist make a preparation for their request, I think. Of course, maybe 30-40 seconds is maximum, I think.
Thank you very much.
Thank you. Raja, I have a question.
Yeah.
In cases of ruptured paraclinoid aneurysms, when in the preoperative images, probably you are not sure whether you will have a proximal control. What's your opinion about carotid artery exposure at the neck?
That's a very good question. In all our cases of paraclinoid aneurysms, we always have opened the neck and prepped for an intraoperative rupture. We always expose the neck in case of paraclinoid aneurysm. But in cases of, in places where I have read the literature that there are, when it is in a hybrid, like yesterday, our learned professor Yuan Li Zhao from Beijing Tiantan Hospital, he showed that he operates in a hybrid. And all cases of paraclinoid, they insert a balloon and they get the proximal control through that balloon inflation, and they can clip the aneurysm more favorably. So that is what my understanding is. We always prepare the neck and expose the carotid before we go in.
Thank you. Well, if there are no other questions, maybe issue we can conclude this webinar with a big thanks to both our speakers today, Professor Takashi Sugawara with his wonderful lecture about cavernous sinus surgery, and Raja Krishnankuti, a dear friend of our association, a member of our association, with a very insightful lecture about how to deal with intraoperative aneurysm rupture, which is of great interest, especially for young neurosurgeons. Thank you to Professor Yoko Kato, who always is present to these webinars of the Alumni Association. And thank you to all the participants. I want to remind that the next webinar will be on the second Sunday next month. And please, Ishu, who is my co-moderator, do you want to say something to conclude this webinar?
One point that about presentation of Raja, that showing our personal videos, like, because we are younger generation, and we are handling aneurysm now, and we are doing it our own, and that's why we are facing difficulties. The young neurosurgeons who are now entering into the either self-practice or they are going to assist, they can learn more, because by seeing the video of a master who is doing aneurysm clipping, they are doing it already very beautifully, and they are doing very nice dissection. It looks like the surgery is very simple. But if I will see the videos, I will watch the videos who are made by younger neurosurgeon like us, like Raja showed, I can learn more, because I can correlate. I can also feel that that's how same way I proceed and I do mistakes. So I suggest that we should put our videos, our personal videos, or either good surgery or bad surgery, and let the people know that how to handle complication, or if we are not able to handle the complication, then you can avoid that complication in future. That I learned from the video of Raja. And last time also in winter seminar, I watched the video presentation by Sandeep Tillari, that bad IC aneurysm, and there the rupture couldn't be handled very beautifully, so he clipped the main ICA trunk, and but the patient was saved. It was a great message from that video also.
Anyway, I also agree very much with Ishu, because we can all improve more if we see also young neurosurgeons cases directly. So thank you very much, Raja, for your videos.
Great honor.
Okay, thank you very much to all of you, and I wish you a great week ahead, and see you next time.